Hi friends, I am Dr. Mayank Uppal. I am consultant in medicine at Sitaram Bhartiya Institute of Science and Research, New Delhi. And today I am here to discuss with you the effects of established cardiovascular disease in a patient who has diabetes and what are the best ways of managing such a patient and giving these patients holistic care for better outcomes. To exemplify this, we'll be discussing a case of a 53-year-old gentleman who works as a corporate employee and has been diagnosed with diabetes 6 months ago. So when this gentleman came to the hospital for a routine checkup, he complained of generalized weakness, and he had a very strong family history of blood pressure and heart disease, myocardial infarction to be specific. He had been a heavy smoker for almost 30 years, but he had quit 5 years ago, and now he was, making small efforts to lead a healthier lifestyle in terms of some regular exercise and improving his diet, etc. He had a history of a heart ailment 3 years ago. When this patient was examined, he was found to be overweight at 92 kgs for a height of 5 feet and 8 inches, which brought his BMI to 30.7. Now we know that the BMI less than 24, between 18 and 24 is ideal, and anything more than 24 is considered overweight, and anything over 30 is considered obese. So he fell in the category of obesity. And his blood pressure was 140/90. When he was evaluated further by a laboratory blood workup, his HbA1c came out to be 8.4%. Also, his cholesterol levels were high, with the LDL or bad cholesterol at 137 milligrams per deciliter, which we know should be ideally less than 70 and not more than 100 in all cases. His renal function test showed a eGFR of 65 and a urine albumin creatinine ratio was 50, which is also more than the cutoff for normal protein excretion. So which means he also was having some microalbuminuria. Now he had been on metformin 1 gram twice daily and telmisartan 40 milligrams every day, atorvastatin 10 milligrams, amlodipine 5 milligrams, and on aspirin and clopidogrel as well. Now, looking at this patient, there are 4 or 5 things that have to be addressed to give this patient a complete and holistic management. So one is that he needs cardiovascular protection from further cardiovascular complications because he's already had a heart attack 3 years ago. He needs microvascular protection because we can see that he's already having microalbuminuria and that needs to be corrected. He's obese, so weight reduction has to be considered. And of course, we need to reach the glycemic goal because he's at 8.4% HbA1c, and we know that the goal for diabetics is to be at an HbA1c of less than 7%. But this goal has to be achieved without adding to any further risk of hypoglycemic events. And then whatever therapy we advise for this patient must be convenient in terms of dosing schedules, because anything that is too complicated or difficult to follow, the patient is less likely to follow and we will not be able to get our desired results. So the primary consideration here was cardio protection to avoid further cardiac injury to the patient and to optimize the glycemic control. Now, by adding an SGLT2 and DPP4 combination, this could be optimally achieved because the benefits that we'll get out of this will be cardio and renal protection. Adding a SGLT2 and DPP4 inhibitor, both of which are oral drugs and both of which can be taken once a day, simplifies the regime. There is early and durable glycemic control. And the glycemic goal, that is, the combination can give you a HbA1c benefit of more than 1%, which is most likely to make this patient reach the glycemic target of less than 7%, and without any added risk of hypoglycemia. The added benefit will be in the form of weight loss that this combination will be able to encourage in these patients. We know that cardiovascular disease is a leading cause of mortality and morbidity in adults with type 2 diabetes. And it is estimated that this occurs almost 12 to 15 years sooner in patients who are diabetics than in patients who are non-diabetics. And this excess risk of atherosclerotic cardiovascular disease in patients with diabetes has been estimated to be at least double from those who do not have diabetes. And this was also validated in major studies like Framingham Offspring study and many other studies. and very importantly, a risk of subclinical cardiovascular disease or cardiovascular disease which is not evident clinically also increases about 4 to 5 times in these patients. So we have to be very conscious about evaluating and preventing subclinical disease in these patients, and should always consider subclinical disease in patients of diabetes unless we are proven otherwise. So one of the recent very good studies which has added towards the evidence of cardioprotection is the EMPA-HEART study. And the EMPA-HEART study studied the effect of empagliflozin on cardiac structure, function, and the circulating biomarkers in type 2 diabetes. And it showed that empagliflozin resulted in early and significant reduction in left ventricular mass regression. It suggested that reverse cardiac remodeling may be a possible contributor to the cardiovascular effects of SGLT2 inhibitors. We know that by the EMPA-REG trial that there is cardiac protection and decrease in cardiac mortality from empagliflozin, but this study pointed out the possible mechanisms which would lead to this benefit. In this era of evolving dimensions of cardiovascular care in type 2 diabetes management, EMPA-REG outcome study, which came out in 2015, proved to be a major milestone, which demonstrated that the CV mortality was reduced by 38% with empagliflozin, and the cardiovascular events as well as MACE in type 2 diabetes was significantly reduced in patients who had established cardiovascular disease. The post hoc analysis of EMPA-REG also demonstrated consistent CV mortality benefit. And mind you that this was irrespective of prior CV events, heart failure burden, or the presence of CKD or chronic kidney disease at baseline. And also this was independent of the baseline HbA1c of the patient. So which broadly means that any category of patient when they were started on empagliflozin, according to the EMPA-REG outcome trials, showed benefit in terms of cardiovascular mortality. Now, since the EMPA-REG trial came out, several mechanisms and hypotheses about the proposed mechanism of action have been proposed, which included, mechanisms like osmotic diuresis and natriuresis, which would lead to BP lowering, then decrease in arterial stiffness and vascular resistance, decrease in weight, and decrease in uric acid and oxidative stress. But none of them have to been solidly proven to be them, but all of them seem to contribute in one way or other to the cardiovascular protection. So it has also been reported that SGLT2 inhibitors may be promoting reverse cardiac remodeling and improve myocardial energies and filling conditions, etc. So the EMPA-HEART cardiolink study also demonstrated results on similar lines, that empagliflozin could probably reverse cardiac remodeling in type 2 diabetes. Similarly, Carmelina and Carolina trials for linagliptin has also shown that the linagliptin is CV safe and renal safe versus placebo, as well as active comparator when it was added to the standard of care in patients with type 2 diabetes. So therefore, we have solid evidence in favor of empagliflozin as well as linagliptin, and therefore EMPA-Lina combination is available and should be used as a first-in-class treatment for patients. When you give a fixed dose combination, you are bound to improve the compliance of the patient because the number of pills comes down, as well as there's cost benefit to the patient. And when an EMPA-Lina combination was used in one of the studies at 24 weeks, it showed that the patient had a statistically significant HbA1c reduction when they were added onto patients with metformin. And HbA1c decrements by EMPA-Lina was to the tune of 1.8% of HbA1c at 24 weeks, when the baseline was about 8.5%. So almost similar to the kind of profile of this particular patient that we are discussing. And 1.8% reduction by this combination is quite a significant reduction. If you just look at the glycemic benefit, and over and above that, the other benefits of cardio and renal protection that SGLT2 and linagliptin provide are also going to add an added benefit. So therefore, this combination is a very valid choice for such patients, and it offers a suitable component in our strategy to achieve the HbA1c control, very importantly, without adding to the risk of hypoglycemia and weight gain in patients, which negate the effect of use of any drug. Therefore, EMPA-Lina combination is a very rational combination which would be suitable for most of your patients as a first add-on to metformin once you need escalation of therapy. And it not only provides effective glycemic control, the added benefits of cardiovascular and renal protection make it the first choice as an add-on to metformin. Thank you.